Okay. So welcome to the Pediatric Emergency Care Coordinator Resource Series. This series is presented in collaboration by the pediatric committees of both the Massachusetts College of Emergency Physicians and the Massachusetts Emergency Nurses Association. Today, we are going to have as our speaker, Kathleen Walz. She is a registered nurse, certified pediatric emergency nurse, and has spent over 25 years at Boston Medical Center and in the role of a senior staff nurse of the Pediatric Emergency Department. She also has 10 years of experience working at Boston Shriners Burn Institute. And she is the founder of the Pieces of Home, the award-winning Pieces of Home Backpack Project. So welcome, Kathleen.
Thank you. Well, it's nice to be here, actually. So my lecture is called No Bones About It, Kids Are Special. So this really, orthopedics is the most popular system by far. Many a kid have chosen a skeleton costume when it's time to dress up. Skulls are pretty cool now, and everyone knows someone who's had a broken bone, so it's pretty popular. Today we just have a really mini lecture combining two of my favorite topics, orthopedics and kids under the age of 5-ish. We're going to focus on what we can do to support these children and recognize potential injuries so that really they can achieve the best outcome possible. So children are not small adults. They a lot of times look a lot like grown-ups. They have similar appearances, similar things about them, but they are very different. Their sizes is the obvious difference for them, but there are things about them that are unique to them, and we're going to talk about those today. So pediatric patients have a reduced body mass, so the force of trauma is distributed throughout their entire body. So it doesn't just localize to the right femur, if you will. It really hits them to their whole core and their whole being. The force is transmitted through pliable and incomplete calcified bones. The kids have limited connective tissue, and they really have weaker abdominal walls, so they don't have as much protection on their whole body. The force affects more organs than they would on adults because the organs are really in a tighter space. They're in closer proximity to other organs and other structures. And really, by nature of the pediatric smaller stature, you really end up with more multi-system injuries whenever they get in trouble or get injured. For me, mechanism of injury was sort of a foreign, unknown topic till I arrived into the ER. And for kids, it really, really, really is one of the most important things to talk about. So what happens is the questions we want to know really are what happened to them, how far did they fall, how fast they're coming, did they land on what kind of fabric land, was it on a bush or was it on hard cement? Really, these are important things to sort of figure out when you're looking at kids. What we do know is that in EDs across the United States, we treat 200,000 children from 14 years and younger. And a lot of them are playground-related injuries every year. And more than 10% of them were treated for traumatic brain injury, which is a significant injury for children. Unattended injury is the leading cause of death for kids from 0 to 19. Even with all our hard work as far as injury prevention, we're still having kids get injured and die between 0 to 19. Severe child injury requires many, many years of medical, surgical, and even mental health support. Families are seriously impacted. They cannot be able to get to their jobs. They can lose their jobs. There's financial costs that they have. And of course, the stress to the whole family when you have an injured or damaged child that's home with you, but is still not able to function as they typically would before their injury. Musculoskeletal injuries for kids are usually in combination with other injuries. So if you have a kid with sort of a fractured rib, you should be worried about what's going on with their lung. Do they have a contused lung? Do they clip their spleen or their liver? So it's really important for us to understand their mechanism of injury to really identify some life-threatening injuries that could also be going on that we might not see initially, but we know will be heading towards us very soon in our department. So what we're going to talk about is high-risk injuries for children less than 2. The ones that we really should be thinking this could be a real big problem for these kids are things that fall from more than 3 or 4 feet high. falls that are 3 times their height. So a 1-foot child, if they fall from 3 feet, that's a pretty important thing for them. If they're 2 feet high, if they fall from 6 feet off a monkey bar or a play structure, that's a big deal for them. And the trauma on their body can be significant. What's interesting about kids is that the fall even can be out of their parents' arms. And I've had parent walk down a set of stairs and trip and fall, and actually the kid falls out of their arms and they fall down 3 flights of stairs. So even in typical life events, we can find big damaging things happen to kids. So fall out of patients' parents' arms, fall off a changing table, any head strike from a high impact object like a baseball bat or anything along those lines. A motor vehicle accident when the kid gets thrown out of the car is a big deal for them. Death of another passenger, an MVA, and things like a rollover, even if the kid stays in the car or stays in their car seat, can be significant for them. So we're going to talk about little boy infant Finn. He arrives with his mom. He's in his little car seat. He's 6 months old. He is quiet when he arrives, but he opens up his eyes and then he closes them. But he's present and with you, and he's awake. Little Finn has many siblings. He is a little fussy per mom, and she noticed that he has a lump on his parietal area, and she'll show it to you when you look at him. Little tidbits for little infant when he comes in is really the baby's mental status can't be really assessed very well unless you wake them up. So sleeping baby is not necessarily a sleeping baby. A sleeping baby can be a baby that is not well and is having a mental status change. So really do your best to wake them up. You can quickly get a quick set of vital signs if you want while they're nice and quiet, but then your assessment should start by looking at them, watching them, seeing what they're doing, and really waking them up and making sure they can attend to what's going on around them and can follow things and looks engaged in their little world. So infants age 0 to 1, one of my favorite age groups. For them, really, 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 that set of vital signs, an accurate, complete set of vital signs is really important. We like to start from least invasive to most invasive, because once you start touching them, they can get really nervous, they get really worried, and they can even be crying because they're afraid of you, especially around that beautiful 8 months when they start to feel stranger anxiety. You'll be the first one on their anxiety producing list. So we really want to get a quiet set of vital signs when you can, least invasive to most invasive. You want to have really good tools for them. So you want to have the right size blood pressure cuff. Your ER doesn't have to have 5. They just need 1 of each size, and you need to know where to find them, because you want to get a good, accurate heart rate. You want to use a nice, appropriate size blood pressure cuff. You want to get a stat probe. Even if you have a couple of sizes, you can really work where you use them, whether it's a great toe or a finger or a palm if they're under 1 month old. You want to have a nice rectal thermometer nearby. And really, an accurate set of signs makes all the difference for you. So even if you throw the stat probe on for a few minutes and step away and do some talking to the parents, you can really see where that heart rate really falls when they're quiet. Don't keep complacent about vital signs. They really are called vital signs for a reason. They give us a nice snapshot of how they're doing with their circulation and their respiratory rate, and how they're doing in the situation they're in. So accurate set of vital signs, and they're important. Respiratory rate, we really like to get them for more than 1 minute for kids under 1, and for sure for 1 minute for kids under like 3 months old, because they're very irregular breathers. So that nice idea of taking it for 15 seconds and multiplying it by 4 does work on people that are, my age, but really doesn't work so well on kids under 1, because they may breathe really slowly and then rapidly for a while, and really slowly and rapidly, and that's normal for them. But if you happen to be counting them in a rapid period of 15 seconds, you're going to get a very high respiratory rate that you may not have to, which is inaccurate. So a full minute is great. For head to toe assessment, you want to do a modified one. You want to do gentle palpation. You want to do least painful to more painful. What I also love about this age group is that they have these amazing reflexes that they get for survival. The rooting, the Babinski, the grasping, the blinking, the sucking, they are beautiful reflexes. We like to see them. We want them to have them. If you're really worried about a child, if you lose any of those reflexes, you should be very worried about it. What I also love about that first year of growth is that it is rapid, it is fast, and they change from doing absolutely nothing to things like pulling themselves up to standing in 1 year. So it is an amazing period of time. What actually also happens during this period of time is so rapid and so fast in what they can do that it's really hard for parents to keep ahead of their developmental changes. So this is a baby that has been laying there doing absolutely nothing for the first month of their life. they're doing eating, drinking and stuff, but they're not moving. You can lay them anywhere you want and they go nowhere. And all of a sudden they learn to lift their leg and they flip themselves right off a changing table. So it's really challenging period of time and it's hard to keep ahead of it. So keep that in mind. They're changing so fast. What we do know about growth and development is that it's linear and predictable. You don't go from sitting up to running. You actually have to learn how to crawl a little bit and then you'll be able to walk. It is predictable. And we want to expect that to be the same for most all kids. Successful ideas to help you with kids if you don't get a lot of children in your ER is that there are a lot of really good cards that you can get a hold of that have normal vital signs for ages. There's some beautiful charts that give you size ET tubes to use, size blood pressure cuffs to use. There's charts that actually will give you, once you figure out their length, they can actually give you a weight and the appropriate measurements and appropriate doses for meds and what you would typically use. And there's a lot of apps that people have noticed are used on their iPhones that actually, like iStat, for instance, they have a you enter a weight, your best weight for them, and then you can actually pick whether they're medical or surgical complaints, or if they're having anaphylaxis, or if they're having belly. You can put in really anything, and then it will actually math out for you what the doses are in meds, which I find it really helpful. And I think it's a combination of all of those is really helpful to knowing you're doing the right thing for the kids when you need them. So for the infant up to 1, there's anatomical differences that are just amazing. They have a lot of them. They're obligate nose breathers. They have much smaller airways than adults, and they use their belly a lot to breathe and to ventilate themselves. So what we need to know in the ER is that it's really important for us to clear their nose, whether you're using a bulb suction or a Yankauer suction. You want to clear their mouth out. Any pressure on their belly can really decrease their ability to give good respiratory effort. So if you're leaning over there trying to put an IV in, you want to make sure you free up their belly to do some nice breathing. If you end up intubating them, you really want to decompress their belly because they need that ability to open up and ventilate better that way. They have open fontanelles and they have a soft cranial vault, which means their skull is really pliable. And there's a lot of room for internal swelling if they have a head trauma, but at some point they run out of that space and they will deteriorate very quickly, but maybe later than you would have expected, just because they have a little wiggle room in there. They have those beautiful fontanelles that we can actually assess for bulging, for increased ICP. And likewise, if they're really dehydrated or coming really sick, that sunken fontanelle can really give you some good information as well. They have a large occiput and a proportionally larger head than adults. So because they have that nice large head, they do lead with their head for everything. So a kid struck by a car or a big fall off a playground or falling off their changing table, they will lead with their head. So you can always debate on somewhat a head strike being part of your differential for them. Likewise, that beautiful large occiput really causes some trouble when you're trying to keep them neutral in C-spine immobilization or keep them neutral to keep their airway open. So a lot of times you will have to put little rolls behind their shoulders just to neutralize them when they're laying on their back. They have an increased metabolic rate, which is actually 2 times that of an adult. So they have increased need for O2 and increased need for glucose. So you want to start leading with giving them that kind of stuff early on. They have an underdeveloped autonomic nervous system and a light fat store on them. So we really need to warm them, and we really need to warm them, and we need to warm them some more. So hats on, little booties on, warm blankets on, wet clothing off as soon as possible, because they will get cold and they will get cold fast. Their circulating blood volume is about 90 cc's per kilo, which is more than adults, which really puts them with more sensitive to volume losses and more insensible losses they will have just because of the respiratory rate and amount of circulatory volume. And they will have true volume losses that are more impactful to them than adults might have. So here we are back at Mr. Finn. So the mechanism of injury that mom presents to you is that she shares that her and Finn were taking a nap on the bed. She said, I really had him tight next to him. I had my arm around him, and that she really woke to hearing Finn crying and found him on the floor, on a hardwood floor next to his bed. So that's some good information for us as an ER nurse. We sort of got a height idea, like how high was the bed? We know what he landed on. We're unsure about loss of consciousness because she actually found him when he was crying. Hopefully he cried when he hit the ground, but we're not for sure for that. So it gives us some good information already as far as what happened to Finn during his accident. So pediatric assessment triangle, which is sort of a across the room assessment that we get of kids, which looks at appearance, work of breathing, and circulation of the skin, gives us a quick idea of how, if we want to turn them as sick, sicker, or sickest, whether two, or of those items are broken, I like to call them, are not right. So for Finn, we actually have him as, and it gives us a good sense of his ventilation, his circulation, his core perfusion, if you can get a good idea of his PAT. So for him, he's quiet, his color is pink, and he has no work of breathing. So for Finn, he looks kind of okay. His airways within normal limits. He has a collar in place that they decided to put on based on mechanism of injury. Whether we keep it on or scan him is another thing. I'll get films. His breathing is within normal limits. His circulation is strong. Peripheral pulses are strong, of less than 3 for cap refill, and his pulse is 140. His AVPU shows him that he's easy to awaken and triage. He responds to your voice, and he moves all extremities. He has no obvious injuries except that parietal hematoma that Mom pointed out to you and that you can appreciate. We're going to place a nice little warm blanket on him and hat. His vital signs are 140, breathing at 26, temp of 98.4, sat of 100, blood pressure 70 over PELP. He's got that little drop off that we noted. He's quiet. He responds to voices at all times. So his app voice is responds to voice. And we really have no new information. He's a well baby with no additional health history that we're worried about. His Glasgow Coma scale puts him at, let's see, his eyes are a 4 for open spontaneously. He cries, but he's consolable. So we're going to give him a 4 for that. And he withdraws to touch, which is great for him. So we actually will Glasgow Coma scale him at 13. Which is good. Our plan of care for him is that we're going to assess his cervical spine. We're going to do a primary and secondary assessment. We're going to think about some diagnostic procedures and interventions we need for him. We're going to make sure we're getting those accurate set of vital signs, put him on a monitor. We're going to do IV and labs for him. We're going to consider social work support, mostly because of the fall for sure. The story seems reasonable to happen, but we also don't want to negate that there might be some other issues going on at home. And we want to really have someone spend some time talking about concerns if we have any. We'll talk about whether we're going to obtain brain imagery or to scan or not to scan them. And we're going to do a little chit chat, talk about a PCAN study with guidelines for us to help use in the ER with some nice algorithms for kids. So for him, he looks good. He's quiet. He has that step off. We're uncertain about the LOC. We don't necessarily need to be thinking of putting a C collar on. We can think about removing it more because he has an isolated injury that we can see. We are a little worried about some other things with Finn, but we're going to walk through that a little bit. So CT or CT, and why do we care? Because a little kid at 6 months old having multiple CT scans over his life is a lot of radiation, and because they're children, the one CT is a lot of radiation for a child. So the increased risk of cancer is really skewed to that pediatric population due to a number of things. They have a longer lifespan. They're younger, so they're sensitive. Their tissues are more sensitive to the radiation. There's a higher incidence of genetic mutations over time, and they really have a much smaller body mass. So the amount of radiation is an increased dose to get through that body mass, right? So there are things that we can use to help us make better clinical decisions and try to omit CT scans for kids that are at low risk. And we can do some things like absorb them in the ER in place of, if they're at low risk, in place of CT scanning. And we're going to talk about that a little bit as well. So the PCAN head trauma study is a prospective cohort study that was published in 2009 in the Lancet. What we like about it is that it included 18 hospitals, which is a huge population, and its mean age was at 7, which means it captured those lower age kids for us. What it really did, it identified low risk groups that do not require head CT, so kids we don't really need to do head CTs on. The largest population was 42,000 kids, or over 42,000, which is a great number for a study. The rules were developed on over 33,000 patients, and they were validated with another 9,000. So it's a really strong study, and there's a website for that. Really what it helped us do is identify children at very low risk for clinically important brain injuries after head trauma. So clinically important traumatic brain injury are things like they are death, intubation more than 24 hours, needing a neurosurgical procedure, or having an intracranial injury and needing more than 2 days in the hospital. So we really want to try to capture, we really want to try to identify what kids do. They identified for us what kids do not actually have a clinically important brain injury based on these beautiful algorithms. So we're going to look at them. So we're going to use the less than 2 for Finn. So when we look at the nice little, the CTs, so the Glasgow Coma Scale 14 or 15, he's at 13 or 14. So he's about 13 for him. So he's less than 2, so we're going to actually follow it through. So what the algorithm is saying to us, if he has one of the following, so for Finn, he has a notable palpable skull fracture. So for Finn, he automatically falls on the yes category. So a CT we recommended for him. And they do about the 13.9 of that population, or have 4.4 risk of clinically important traumatic brain injury. So that's where Finn would fall. But many times the kids will present with a Glasgow coma or fall, don't have an altered mental status, and don't have anything palpable in skull. So a lot of our kids will fall down that no algorithm and actually put you into one of the following. So you're going to look down, is there a severe mechanism that you worry about? Are they not acting normally? And if they are, then you're going to fall to the yes category, and you're going to do so observing them or do a CT based on a number of things, which we'll talk about. Can you see how it really just help us limit who actually needs CTs and who doesn't? So we use this a lot in the ER. So once you get down to CT or ED obs, you really, a true ED obs is that you just observe them in the ER for at least for 4 hours post-injury. So if they come in at hour 3, you really don't need them there for more than an hour or 2, right? So it's post-injury. So you can ED obs them if they have no significant extracranial injuries. There's no other indications that you're going to admit them anyway. Are they alert and back to normal neurological exam for them? Are they back to their baseline? Have they been able to tolerate POs? Do you have no suspicion for abuse and neglect? And does the family live near the hospital they can get back as quickly as they need to? And do they have a reliable caretaker or pediatrician that can be in close contact with them? And that the parents need to understand clearly why they need to come back to you. So on Finn, he got an x-ray and it showed that he had a skull fracture, which is what we suspected at the beginning. For him, we realized that a venous bleed typically can be tolerated by these kids. Things that we're going to do is going to keep his head of bed elevated. We're going to keep him NPO. For him, we're going to decide to do a CT for him based on the algorithm. We can start with an x-ray first and then do CT as well. Sometimes we'll do them a little out of order, or we'll start with a head CT, start with an x-ray and then decide if we truly need that head CT. We want good neural checks with pupils. We really want to do a lot of close monitoring for Cushing's triad, which would be a decrease in heart rate and an increase in blood pressure, which is concerning if we're seeing those, because really we are looking at a kid was having increased intracranial pressure. So we really need to keep our eyes on that, which means frequent vital signs and really looking at those vital signs and seeing if they make sense. Are they doing what we don't want to see happen? So decreased heart rate, increased blood pressure. Skull fractures do heal. Sometimes they go to the OR if they're depressed and then we need to lift them off the brain. For the most part, if they're just linear, we can actually just let them heal in, I think, about 4 weeks. We want to check the ADFU for these kids, and they can do it often because they do change. They may be doing fabulously, and all of a sudden they're hard to wake, or they don't only respond to your voice or to you moving them. So you really want to keep in mind you need to check that often for kids. You want to think about a surgical evaluation for the head trauma and the fractured skull. For him, he would go to our ICU. If you have an adult-only hospital, these are kids you probably want to think about transfer in case they decompensate over time. You really want them to be in the right place for that. You want to think about concerns for 51A, that's a social worker involvement to be talking to them. You really want to think about a skeletal survey. For Finn, later on, we actually found a skeleton, we found a fractured high fractured femur for him that could be related to the height of the bed and the way he fell, but we really should be thinking about what's going on with them and think about a skeletal survey to get a better look at him. So fortunately, this approach that we just used for Finn is applied to many kids in that with many different mechanisms. So the kid that falls from the arms of a mother onto the floor or down steps is in that perfect category. So everything we did for Finn, we can do for them. Our car seat that wasn't secured into the car during a motor vehicle crash has that same mechanism. Fall from stroller, fall from high chair, falling down steps in a walker, a fall from height that is equal 3 times of their height is all the same. So the good news is if you get it down the first time, you can use it for many other things. So we're going to talk about preschooler Sam. She's a 4-year-old girl who arrives into ER having pulled her hand out of her mom's hand, and she got struck by a car. The story of the caregiver says that she was struck to the left side, no damage to the car. She was found beneath the car. The car did stop immediately, and there was no LLC noted at the scene. So for preschooler Sam, she's in the development, she's in preschooler age 3 to 5. What we want to know about these kids is that they're magical, logical thinkers. They interpret words literally and phrases very literally. So things like if you say, hey, I'm going to put an IV in you, they're thinking about grandma's IV plant in her house, and they may actually think that you actually are putting an IV plant in their body. So you want to use things like a small straw when you talk about IVs with them. We use carelessly sort of words like we're going to put you to sleep, but the only thing they may know about being put to sleep is when their dog went to the vet and never came home. So you want to make sure we use words like we're going to try a special medicine, and it's going to give you a special sleep, and it's going to help you feel better, and it's going to help you not have as much pain. So you want to use your words, choose your words carefully with this age group. They're going to ask a bunch of questions. I like to answer them really directly, really clearly, and promise them nothing that you can't give them. So sure, I might say, we're gonna have to roll you. Would you like to hold my hands? Or do you want me to hug you? So you give them some choices that you can live with, but you're not going to say them, do you want me to roll you? Because that is not an option you have for them. So I give them choices, but they're ones that I can be true to them and allow them to do. They're afraid of pain. They're afraid of darkness. They're afraid of their body being mutilated and not well. They do feel like if you put an IV in, or if they have a cut on their leg, they really do think that they're going to bleed to death and die. Like everything feels ominous to them and frightening to them. They worry about being loss of control, that they can't move their arm if you put that IV in. They're afraid of dying, and they're afraid of being alone. So those are easy things for us to fix, right? We can reassure anybody that your dad's going to be here with you the whole time. Once we're finished putting that cast on you, your bone's going to heal, and you're going to be able to walk. In the next couple months, you're going to be running around the house being fabulous. So I think a lot of things we can do, we can keep the lights up. So whatever we can do to eliminate fear for them and trust them that we are going to get them better is better for your whole day and for their stress level. Their anatomical difference is that they really have a proportionally large head and very lax neck muscles. So their head does lead a lot of times forward when they have any mechanism of or impact on their body. They're structurally, their whole body is much lower to the ground. So when they get hit by a car, they're hitting the core of their body, versus you and I would be hitting our lower leg or the center or a thigh. So for them, you're actually getting a full body impact when they get hit by a car. Their chest wall is pliable because they're not fully formed, and they're not full-grown adult bones. So they're a lot more pliable. There's a lot more wiggle to them. Their ribs are actually horizontal too, so they don't have that lower ribs. They're sort of protecting the middle of their belly. They're actually more straight across, so a strike to their abdomen really gets at all their major organs. Their belly walls are thinner. They're weaker, and they don't protect those abdominal organs as well as in adults. So you want to be thinking about belly trauma. So when they get hit to the middle of the body, you should be thinking things like they could have a femoral shaft injury, they could have a thoracic and intra-abdominal injury, and they also could have a head trauma or head injury from the mechanism of their fall. So if you see a kid that gets struck by a car, you should be thinking multi-system at all times. The other things for kids that they really compensate volume loss, so blood loss, fluid loss, by kicking up or increasing their heart rate, And when they drop their blood pressure, it is a very late sign of hypovolemia and a very ominous sign that you are at decompensated shock at that time. So the approach to the presole is the same: accurate vital sign, least invasive to most invasive. It's important to have tools for this age, which we talked about: the right size blood pressure cuff, apps, appropriate weight-based tools if you have them. You want to do a quiet, modified head to toe. You want to stay away from big injuries and do gentle palpation other places. You want to enlist their help. Hey, can you hold this while I put a Band-Aid on that? Can you hold this tape for me? Offer limits and offer reasonable choices for them. Use clear language and clarify all their questions before you get started. They love Band-Aids, they love bandages. The more you can cover up, the better. And it also decreases their stress level as well. So whatever you can do to help them with that would be great. Let's see, so here we are, the difference between adult and child. There's a lot of them still. So the characteristics of their head and body. The child's head is much larger than their body. The adults really have a smaller head in proportion to their body. Their fulcrum, or their weight, where they tip their head on their spinal column. For children, it's C2, C3, so it's a much higher fulcrum for them. For adults, it's a lot lower. So we get a lot of flow with the high balance of their head, and the heaviness of their head puts them at a high flex with injuries. Their neck muscles and spinal ligaments are very weak and lax on children. For adults, they're strong and more stiff and less elastic, so they hold their self a little bit better. The vertebral bodies on kids are anteriorly wedged, and they're cartilaginous, so they're a little more soft and a little more pliable. So they're wedged forward already. So when the mechanism pushes them forward with that heavy head, they will flex forward and move forward a lot more than adults will. Their articulating facets on their spinal column they don't link in as well as adults do, and we'll show you on the next slide. They're more horizontal and a little more flat, so they slide more. So they may not see fractures in their spinal column, but you may actually see a pulling of their spinal column, but not the bone structure. So you want to keep that in mind. You may have spinal injury, but not really spinal column or bone injury. So here's a typical look at the child versus adult. See how they're more flat with each other. They're not interconnected as well, and they do slide a little more. So they're set up for this beautiful heavy head on a very slippery kind of spinal column. They're set up really for a lot of flexion in that area and extension both ways. So here we are back at Samantha. She's a 4-year-old, arrives on a spinal stabilization by EMS. Mom is at her bedside. What's interesting, these patients can really come to you carried in even. I had one of my first C-spine fractures on a 2-year-old that mom walked into the department with. And I could see that she was holding herself very still and sort of self-splinting, but she ended up with C-spine injury, and she actually ended up with a halo traction, but she walked in and on mom's hip. So remember, they can come in walking in with you. A lot of times people scoop and run with them, but you are going to keep focus on the mechanism of injury and your good PAT assessment and really mechanism of injury for them. Things you want to think about is the number 20. So think 20. Speed more than 20 miles an hour. You should be thinking that's a significant injury or significant force on somebody. Fall more than 20 feet, also a significant force on someone. For kids, you may even need to be thinking about 3 times their height as being significant for them. Major car accident, death of another passenger, inappropriate restraint use in that car is a big deal for them. It makes them unsafe in even a car, even if they remain in it. So a 3-year-old that is sitting in a just a booster seat with a belt across their belly and a belt across their neck that is really set for adults and for kids that are much taller, what you actually are doing is distributing a lot of the force that the seatbelts are used to distribute across our bodies when we're adults. You're actually getting them maybe across the neck, you're getting it right across their belly. And that is what we're trying to protect them from. And if they're inappropriately restrained, that is not happening, that they're a setup for that. A lot of times we have kids that are, 6 or 7 or 8 that just have a belt across their waist. So the mechanism of the injury flings them forward, their heavy head goes forward, and you actually get sort of a ligature injury right across their belly. So keep in mind that we really want to know what kind of car seat they're in, what part of the car they were seating in, did they stay in their car seat, and what happened to everyone else in the car. Any cervical region pain they have is, of course, C-spine assessment needs to be done and collars need to be stayed on, and any altered sensation in their extremities, upper extremities. We use KEDS a lot for kids, which are what we use to extricate adults out of cars. You put it around them and lift them out to keep their C-spine immobilized. But a lot of EMS, you'll see them use them for kids as well, because you kind of get their whole body wrapped up sort of in a burrito, if you will, and keeps them nice and safe. And they'll use towels around their neck also. It's really important for you to keep all size collars in your department. There's a beautiful array from infant all the way up. You at least want to have 1 or 2 of each. It's just a special order for your department. But at least if you have them, you can use them and then order them as you need to. But you should have them if you're seeing kids. So our assessment for Samantha, her quick across the room assessment is that she's calm, she's pale, she has no increased work or breathing. And we would call her sicker or sickest for her, because she's got a couple breaking things. She has no increased work or breathing, but her color is pale. She is calm and not responding very well to you. So she has increased work of breathing when you look at her. So when you look at her closely, she has increased work of breathing. Her breath sounds are clear. Her airway is within normal limits. Her circulation looks broken to you when you get a heart rate of 165. Her capillary fill is less than 5. Her neurological exam, she responds only to pain, which sort of puts her at a Glasgow coma of 9. She has no bruising, no guarding. Her FAST is negative at the bedside. She has warm blankets and a warm room. Her FACES scale, we would put her that she says she hurts a lot. She can point to that when you wake her up. She has a laceration on her forehead, and her shoulder has an abrasion. She has a deformity to her right lower leg, and she does have a pulse. So the Canadian C-spine rules that we're used to using for adults and the Nexus guidelines don't really apply to children. So the best evidence out there is really comes from a pediatric cervical spine clearance working group algorithm that was created by the Cervical Spine Clearance Working Group out of the Academy of Pediatrics. And it really just is another beautiful algorithm to help us decide what we need to do for these kids. So like any, you start with the Glasgow coma scale, you pick it the 14 or 15 or 9 or 12, and then you're going to work your way down the algorithm. So for someone like her that has a Glasgow coma scale of 9, you're really looking at does she has the potential to improve her mental status to a 14 or 15. So you're going to go with yes or no. So for her, I'm going to say probably no. So for her, she's going to, oh my goodness, I have my little Maureen's little faces on my algorithm. So she's going to end up being, she's going to end up needing a CT, because she's going to fall into anticipation that she will improve to 14 within 72 hours. We're going to guess her at a no. So she's actually going to get a CT, and then we're going to look at the anticipate that the child will improve. And if not, you're going to be thinking about MRI. So it's a nice little algorithm. You can actually walk it through, and it really just is a nice guide for this. And it really, the whole goal of it is really to focus on minimizing the risk of missing injuries, but also protecting patients from unnecessary imaging in the complications of injuries, of imaging too much for these kids. So it's a complicated algorithm, but know it exists and use it when you can for those patients. So diagnosis for her has head lack. Should we assume that she has a head trauma just by of the lack and the mechanism of injury in her Glasgow coma? This young lady had a tib fib fracture of the left and a distal tib fib of her right. She's going to go to the OR for repair of that. Plan of care for her was CT based on the PCAR and mechanism of injury. And labs were drawn. She got x-ray of femur, hip, knee, so above and below the injury for them. OR plan, type and screen was sent on her, of course. Pain meds, repeat your vital signs over and over again. Intervention as needed. For her, her heart rate, that elevated heart rate for her was concerning, right? So can I go back? I bet I can, right? So for Samantha, when we had her at the heart rate of 165, we really want to be thinking about fluid bolus for her because her C is broken. So her AB looked fine enough. We're going to have O2 on her. But for circulation, we really want to be thinking of fluid boluses early. So the 165 and the capillary fill of less than 5 gets her a 20 cc per kilo bolus. So we are going to give that to her, and then we're going to reassess her, right, really quickly. So for Samantha, we would really call her at hypovolemic shock. She's tachycardic. She's got an ominous blood pressure. Her drop in blood pressure is ominous, but for you and I, we know the heart rate of 165 is ominous for her. It's showing us that she's hypovolemic. So we're going to give her the 20 cc per kilo bolus. We're going to put 2 IVs in. We're going to reassess after that bolus, and we're going to get after that a nice 148 with a capillary still 5, which is still a problem for her. So for her, we're going to give her another 20 cc per kilo bolus. We're going to reassess her. We're going to see that her heart rate is 128 and her cap refill is less than 2. So for her C, we're going to be sitting better. So we're going to intervene when we see the ABCs not great, and we're going to do that sooner than later. So we're going to stop there with her C because we're happy with a cap refill of 2 and a heart rate of 128. And then we went through and did all the rest of the things for her. So I don't want to leave you dangling with that 165, because what we do know about kids is vital signs are really important. So in your department, you really have a pediatric vital sign normal range chart. I love this one. It's so helpful. We have it on all our blood pressure, portable blood pressure machines. We love it. The aides use them. We use them. We know that kids compensate by increasing their heart rate. So if we see a high heart rate like Samantha of the 165, you really want to intervene on that sooner than later. If their heart rate is elevated, we want to do fluid resuscitation, which we did do with Samantha. And they lose up to 30% of the blood volume, that's when you actually will witness a drop in blood pressure, and not before that. So they can be really have low blood volume, and we still see an adequate blood pressure, because it really takes about 30% of them to start decompensating with their blood pressure drop. It's an ominous sign. If you see a blood pressure drop for kids, you are way behind and you should get going fast. So monitor that child's heart rate. That's the most important part for them. Volume loss in kids for a typical fractured ulnar, you can lose 250 to 500, humerus 500, femur 15, pelvis 200. So you can get shock from a fractured humerus for children. So let's look at it. Fractured humerus for a 25 kilo kid, their circulating blood volume is about 2 liters. So they could lose upward of 500 cc's just by having a fractured humerus. So that's about 25% of their volume loss. So you actually could see a lot of tachycardia with that. And pretty soon after that, you could actually see a drop in blood pressure, and you can be way behind. So early intervention is really important for them. Their heart rate drives their volume loss. It helps them compensate. So fortunately, Samantha's little like tachycardia, a significant mechanism of injury, we can use that plan of care for many kids in that, and with many different scenarios. So a kid from head trauma, child abuse, and maltreatment falls into the Samantha sort of story in our plan of care. Falls from a monkey bar more than 3 times their height, 3 feet, or 3 times their, well, hold on. So greater than 3 feet or oh my goodness, I just been playing on 3 times their height can really be a significant mechanism for them. Their monkey bar falls, fall out of a window, and bicycle crash. All is the same plan of care that we use for Samantha. So pearls for me, for you, for kids is mechanism of injury is really important. That kids are not small adults. That respiratory assessment is a key vital sign for them. It helps us figure out where they are. Kids compensate by increasing their heart rate before you'll ever see a drop in blood pressure. Blood pressure is a very late sign for them. Early intervene with blood pressure early. You want to do fluid boluses, but after 2 boluses of fluid, you really have to go to blood. You can't really place blood with saline. So after 40 cc per kilo or even 60 cc per kilo boluses, you need to really be thinking about blood next. Accurate vital signs. They're called vital signs for a reason. Use age approach with distractions to get yourself a solid set of vital signs, and do them often. Reassess them often. Lay your hands on them often. They change right in front of your eyes. 10 or 15 minutes into the case, you'll all of a sudden have a rigid abdomen. Tell kids often that they are going to get better and that you're here to help them, that the whole team is there to help them. Let them know that you're going to get them better. I recommend EMPC, PALS, and TNCC to help you be better at watching kids and being better at assessing them early and knowing what their mechanism is, and really knowing what you should be looking for injuries for them. So you do make a positive impact in a child's life. Enjoy them. They're fabulous. And we make a difference when we see them in the ER every day. So thank you.
Thank you, Kathleen. That was a wonderful presentation. I hope all of you who are watching this video will check out our other videos that are on the Mass ACEP Pediatric Resource Site. And have a great day.